Good morning. Today we're going to talk about Chapter 12 and renal problems. Probably one of the most common symptoms that you'll have patients present with is dysuria, and that's that subjective feeling of burning or pain when they go to the bathroom to urinate. You will see frequency and urgency. You may also notice hesitation. It can be a result of several medical conditions, which we'll talk about, or certain medications, and it's most often associated with infections of the lower urinary tract system. So some of what we need to consider with differential diagnosis is that it's often associated with a bladder problem, and it's rarely associated with a kidney disease. You might say urinary tract infection, and a layperson may call it a kidney infection, and they are typically not the same. Also worked into the differential diagnosis, there can be issues with the prostate, the bladder, or the urethra, and other conditions that are associated with dysuria may include a bladder tumor, chronic renal failure, nephrolithiasis, and diseases of the upper urinary system. If we're considering diagnoses that are outside of the renal system, that could be sexually transmitted infections, vaginitis and prostatitis. Women, when working up a differential diagnosis for dysuria, need to be questioned if there's any vaginal discharge or irritation. And then some other symptoms that may help you to differentiate your diagnosis include if there's been any urethral strictures, prolapsed uterus, pelvic peritonitis, or cancer of the cervix or prostate. When your patient comes in complaining of these symptoms, the first thing that you're going to want to do is check for urinalysis. It's the easiest, most non-invasive, and least expensive way to identify if there's any UTIs and help to differentiate other kidney issues. And then once the cause is identified, then you can begin to work towards treatment. Another condition that you may see in primary practice is blood in the urine. It can be visible or it can be occult, meaning it's not seen, that it's small in nature. It's characterized by more than 3 RBCs per high power microscopic field, meaning HPF. You can also have transient hematuria that's just a one-time thing, or persistent that occurs on 2 or more occasions. The urine color is going to change. It can go from a light pink to a dark red. It may take on a smoky appearance. It may appear as a light shade of iced tea in color. That's dependent on the amount of blood that's noted, what dietary intake has been going on, medications, dilution, and the pH. We know that age and gender and activity level of the patient need to be considered because these can have an impact for having blood in the urine. When working on your differential diagnosis, it's important to know a drug history, dietary history, and when a female's last period was. Many medications can cause hematuria. That can be your beta-lactam antibiotics, your sulfa drugs, NSAIDs, rifampin, Zipro, Tagamet, etc. Dietary substances that can act as a bladder irritant are coffee, spices, chocolate, alcohol, citrus fruits, and soy sauce. On clinical presentation, for someone that's complaining of hematuria, it's important to see if there's been any strenuous exercise, any infections, any problems with the kidneys, family history, or even any recent travel. On exam, you may notice that there is CVA tenderness, assessing in the lower back by palpating, thumping the lower back where the kidneys are. That may be indicative of pyelonephritis. Doing a good abdominal assessment, you may note for a neoplasm any polycystic kidney disease. Suprapubic tenderness may indicate a bladder etiology. If there's a urethral discharge, there could be urethritis. And then if there's an enlarged or tender prostate, you could have BPH or prostatitis. To help narrow down our differential diagnosis, some diagnostic tests that you would conduct, we've discussed the urinalysis. If you suspect that it's of a renal origin, you may want to check an ANA, immunoglobulins, chemistry, a CBC, an ASO titer, and a VDRL. Also, if you've done the urinalysis, it's important to do a urine culture and sensitivity if that urinalysis shows any potentials of infection, so that you know what the organism is and the antibiotic that's appropriate to treat the infection with. If these tests are not giving you the answers that you think that you need, there are other exams that can be diagnostic tests that can be ordered. A phase contrast microscopy, which looks at the morphology of the RBCs, an IVP or renal ultrasound, CT scans, more blood workup, and a cystoscopy can be done to evaluate an upper urinary tract issue, and that would be performed by a urologist. Some of the causes of hematuria, they can be grouped together according to the anatomical site of the blood source. If it's isolated, it could be bleeding anywhere from the renal pelvis to the urethra. If the RBCs have cast, it could be an injury to the nephron. If it's gross hematuria, acute cystitis or urethritis. Proteinuria and hematuria may indicate a glomerular or an interstitial nephritis. And then if you have a colicky flank pain to the sides or back, it could be ureteral stones. Okay, let's talk a little bit about proteinuria, which usually indicates a renal pathology versus a lower urinary tract issue and originates in the glomerular system. It can be functional and caused by an acute illness, emotional stress, excess exercise, or a benign process. It can also be the overproduction of plasma proteins. If there's intermittent proteinuria, it can be asymptomatic and might just be found incidentally on a urine dipstick. And the most accurate way to quantify protein in the urine is with a 24-hour urine collection. Causes of proteinuria could be benign and functional. It could be some orthostatic proteinuria, could be caused by exercise, environmental conditions, fever, or an acute illness. When identified in low-risk patients, the urine should be tested for a Bence-Jones protein, which can be seen with multiple myeloma. And if the excretion rate of the protein is more than 2 grams in a 24-hour period, is more considered a glomerular cause. When trying to work up proteinuria, some tests that you would perform would be a full chemistry panel, a fasting blood sugar, lipid profile, a urine culture and sensitivity, a CBC with a diff, and then trying to determine what your excretion rate is for protein, and if between 3 and 3.5, that's considered more nephrotic syndrome and to refer to a nephrologist. Management of the proteinuria depends on the underlying cause. We know that ACE inhibitors are found to reduce proteinuria by decreasing intraglomerular pressure. And if you're concerned that you have a patient that has increased lipids or elevated BP, you need to treat those individuals aggressively because we know how those systems can impact the kidneys. And then patients with chronic renal failure should be managed aggressively. Another condition that you may see commonly in primary practice is urinary incontinence, which is the involuntary loss of urine from the bladder. It's more frequent in women and may be considered normal, even though it is not a normal condition. And in gentlemen, it's seen more in the older gentlemen and due to enlarged prostate. You can have transient urinary incontinence that can be caused by delirium, infection medications, and then there can be persistent, which is categorized as stress, urge, overflow, and functional incontinence, and we're going to talk about those. So the pathophysiology of urinary incontinence, we know that the urine, it's a storage and release type of system. If there are concerns that there's CNS involvement, there may be brainstem center issues that impact whether the bladder relaxes and fills, and it also controls how the sphincter closes. There is also somatic stimulation, which impacts the contractions of the internal sphincter and control of the external sphincter. As your patient is getting older, we know that there can be age-related changes, such as decreased bladder capacity, increased post-void residual volume. There can be increased nighttime excretion of sodium and fluid. There is the overflow phenomena that can be related to a benign prostatic hyperplasia, BPH. And then also there can be weakness of the pelvic floor that can be seen in women. And then with females that are going through or have been through menopause, there's estrogen deficiencies. And we know that there can be atrophy of those tissues. and that can impact the internal and external sphincters in that area. When someone with urinary incontinence presents, it's important to get a good medical surgical history. You want to know as much as you can about their voiding history. You also want to do a good physical exam and identify any causes such as stroke, Parkinson's, and you also want to assess their functional and cognitive abilities. Also on clinical presentation, you want to do a detailed exam, especially of the abdomen, to rule out if there's constipation, fecal impaction, any masses, or distended bladder. A pelvic exam will allow you to assess for pelvic muscle strength, if there's been any uterine prolapse or any other problems that may impact the perineal structures. It's important to look at the skin in the area. Is there atrophic vaginitis because there's decrease in the estrogen in a menopausal woman? If you're assessing in a gentleman, are there any abnormalities in the foreskin, the penis, or the perineum? It's important to assess for congestive heart failure because with those individuals, you have extra strain on the heart, and you can do a cough stress test, which will allow observation of any urine loss with a full bladder. Other diagnostic tests include a urine and a CNS, lights, BUN, creatinine, calcium, checking for the blood sugar, doing a catheterization to assess for a post-voidal residual. You may consider ordering tests that are going to check for urodynamic status, such as cystometry or a cystometrogram. These are all going to help indicate the amount of a retained urine. And then you may also order a renal, transrectal, or a pelvic ultrasound to further add in your diagnostic test. Your main goal is to try to identify the type and the etiology of the incontinence. If it's persistent, you want to evaluate if there's been any delirium, dementia, any neurological conditions. If it's overflow, if there's been any injury to the sacral cord or outlet obstruction or diabetes. If you have urge incontinence, you want to assess if it's hyperactive or a poorly compliant bladder. For stress incontinence, assess for laxity of the pelvic floor, issues with bladder outlet or sphincter weakness, and then also chronic retention or overflow could be related to the prostate, a stricture or a cystocele, and for many individuals they may have a overlap of several of these pathologies. So management is the key goal of stress incontinence. We know with these individuals there can be involuntary loss of urine related to coughing, sneezing, or laughing. It's important to have them be aware of Kegel exercises, how those work, and the strengthening that can occur in helping the floor of the pelvis to become stronger. If weight is an issue, weight loss will help decrease the pressure that is on the bladder. There are physical therapy programs that will help with electrical stimulation that can help with strengthening the pelvic floor. It's also important to have the patient be just aware of their symptoms. If able, you want to eliminate diuretics. The class of medicines, the alpha adrenergic agonists, are known to improve muscle tone in the urinary tract, and then if there's continued issues, then surgery may be an option. The next type of incontinence we'll talk about is urge incontinence, and that's involuntary leakage of urine resulting from the inability to delay voiding. So it's important that these individuals have scheduled voiding times. Try to make it to the bathroom every hour, 2 hours, whatever their perceived time frame is, so that the bladder does not get overfull and they don't have the run over syndrome. It's important to manage their fluids, and then also these folks may need to be on medications to help with some of their symptoms. One may be an antimicrobial to help if there is an underlying infection that is causing some of the issues. Topical estrogen helps with the elasticity of the tissue. Anticholinergics, tricyclic antidepressants have all been used to improve neuromuscular function of the bladder and the sphincters. Then if there's any issues with stones or tumors, those need to be identified. Another condition that may be common is overactive bladder, and this includes urgency, frequency, and needing to go to the bathroom more often at nighttime. It's all associated with involuntary contractions of the detrusor muscle, and it can be multifactorial. It could include disorders of the lower urinary tract, what you take in, medications, neurological conditions, and in women can be impacted by anxiety and depression. Management of OAB first starts with identifying women that have a problem. Women may not want to talk about these symptoms with healthcare providers, so it's important to ask the appropriate questions. Antimuscarinic agents are the most commonly used medications in this condition, and they block the parasympathetic stimulation of the muscle by blocking acetylcholine. Another incontinence issue is overflow incontinence, and that's involuntary leakage of small amounts of urine, and it's caused by an overdistended bladder where the individual does not feel the need to void, and it could be due to a variety of reasons, whether it be muscle issues, outlet issues, hyperplasia, blood sugars, or use of medicines. The management of these conditions include treating the underlying condition, also encouraging the individual to have scheduled toileting times. There is a maneuver called the Creed's maneuver that you can instruct your patient on, where you can apply pressure over the symphysis pubis and slowly pressing down. That helps with this maneuver helps the patient to void when they may have difficulty, and is particularly helpful in patients with spinal injuries. And then there's the use of medications such as alpha blockers. Next, let's talk about functional urinary incontinence, and it can be caused by outside factors of the lower urinary tract, such as delirium, fecal impaction, lack of manual dexterity, mobility issues, medicines that you may be on, and alcohol. The management of this condition is to remove barriers. So if you were concerned that fecal impaction was causing a functional urinary incontinence, you need to work on their bowels to get those going so that hard stool is not impacting flow of urine. It's important to educate these individuals on scheduled bladder and bowel regimens. They may need to use collective devices. They may need physical and occupational therapy, help in making habits on going to the bathroom. They may need bedside commodes at bedside. A caregiver may be needed to help get to the bathroom in time, and if there's continued issues, surgery may be required. If you have a patient that you're managing functional UI on, it's important to have frequent follow-ups, and then once they're stabilized, you could go to quarterly for medical management and to assess for any incontinence concerns. Monitor the patient for adverse effects of the medication and if there's any orthostatic hypotension issues. And then periodic urinalysis should be done to see if there's any urinary tract infections. Let's talk next about lower urinary tract infections, or a UTI. It occurs when the sterile conditions of the urinary tract have had bacteria come into it. If it's in the urethra, it will be termed as urethritis. If it's in the bladder, cystitis, bladder wall, interstitial cystitis, and if it's in the prostate gland, it's prostatitis. Our UTIs can be classified as acute, a chronic, or a complicated. So an acute infection is characterized by the onset of the infection in a previously symptom-free individual. Chronic would be infections that could be caused by obstructions, having an antibiotic-resistant bacteria, or presence of multiple strains of bacteria. And then complicated UTIs are accompanied by factors that can cause more issues with the infection, and this could be such as elevated blood sugars. On the causes, UTIs are more prevalent in sexually active adults, very young children, and frail older people. Predisposing conditions that may impact it would be a suppressed immune system, pregnancy, urinary obstruction, catheter dependency, and then neurogenic bladders and blood sugars. And the reason blood sugars are so important in this, if your blood sugar is elevated, you have more free-flowing glucose through the bloodstream, which is going to act as food for any type of infection and allow it to grow. So if you have someone that is presenting with urinary tract infections that are more chronic and you're seeing them more frequently, if you have not checked for a blood sugar, it's important to do that, because this may be the first symptom that you see of of diabetes. So the patho of a UTI is usually occurs as a result of contamination, typically from the patient's own GI tract. Fecal contamination secondary to poor perineal hygiene, unprotected sex, or anatomically shortened urethra in women are very common. This is when you educate your patient on wiping from front to back for urine versus back to front. Also, spermicides adversely alter the vaginal microenvironment and may predispose the area to bacteria. And then in your patients that are immunosuppressed or catheter dependent, you may notice more infections. We also know that elevated pHs in the urine create a medium in which bacteria can grow. Renal stones can also create bacterial growth, and approximately 80-90% of all UTIs that are uncomplicated are in women as a result of E. coli, which is cross-contamination from the rectum. And Candida may also be a causative agent in complicated UTIs that fail to respond to antibiotics. Clinically, they may present with dysuria, frequency, urgency, having to go more at nighttime, hematuria, lower back and suprapubic pain. They also may complain of a cloud or a foul-smelling urine. When you're working them up, it's important to get a clean catch. Midstream urine for urinalysis. It may show that there's a cloudy appearance. It may indicate that there's blood in the urine, that there's elevated levels of leukocytes and nitrates, and you may see that there's RBCs, WBCs, mucus noted in the urine. When your urinalysis shows that the sample has greater than 100,000 organisms per milliliter, this is indicative of infection. Also, the presence of clinical symptoms. A urine culture is considered the gold standard for laboratory confirmation of a UTI. Your differential diagnoses would include, for a UTI, tumors, an upper UTI, vaginitis, STDs. Lower UTIs do not typically present with signs of septic illness, such as fever, chills, flank and CVA tenderness, even though I have seen CVA tenderness in UTIs, and WBC cast. Treatment with antimicrobials is the first line. We are noticing that there is increased resistance to ampicillin and the sulfa drugs. Nitrofurantoin seems to be the most effective on gram-negative and gram-positive cocci, and you would treat for a 7-day regimen. The Bactrums are also effective, and a 3-day regimen for an uncomplicated UTI would be appropriate. And then also fluoroquinolones such as your Cipros have a widespread efficacy. If your pregnant mom presents with UTI symptoms, it's important to note that you can have premature delivery, and if a UTI is kept and not treated, treatment may include amoxicillin, nitrofurantoin, or cephalexin. Most treatments for pregnant women is about a week. The fluoroquinolone should be avoided in pregnancy. And then if there's a history of UTI, it's important to talk with your patient about postcoital prophylaxis. And if you have a fungal component to the UTI, fluconazole 200 milligrams daily for 7 to 14 days would be appropriate. If you have individuals that are getting ready for urological procedures or have had a bladder catheter removed or have some structural abnormalities, treatment may also be indicated for these folks. If you have a patient that has chronic UTI, prophylactic treatment may be an option, such as macrodantin, and then also it's important, they may need it just after sexual intercourse. Antibiotics may also relieve the pain and discomfort of a UTI, and typically interstitial cystitis does not respond to antibiotics. So if you have a patient that has that diagnosis and they present with symptoms, it may not often be what is the appropriate course of treatment. It's important when you're doing follow-up for these folks that you get a midstream clean catch urine to assess that infection has resolved, and then with individuals that have indwelling caths to have those changed every 4 to 6 weeks. Maintaining good nutrition and good urinary output is important to make sure that the flow of urine is going and urine is not sitting in the bladder. It's important to identify any of obstructions and have those removed, and then prescribe analgesics for patients to reduce pain associated with the UTIs. And this could be your peridiums, your azos, things like that. Patient education for these patients, it's important that they notify you for changes in conditions such as flank pain, hematuria, or if they are not responding to treatment. It's important that your patient understand that a full course of antibiotic therapy is necessary, and not to stop when they are feeling better, to increase their fluid intake to about 8 ounces, 8 glasses of water a day, and that it is okay to drink the cranberry supplements, cranberry juices, and take cranberry supplements if they so desire. Depending on the patient, you may have send them home with medications that they will self-medicate with after education that you've provided them. It's important that the perineal area receive good airflow, and wearing cotton underclothes will help facilitate that. For ladies, avoiding harsh soaps or feminine hygiene products will help to be less caustic to the tissue in the peritoneal area. Discuss the use of condoms. Use proper self-cath techniques if you're having to do self-caths. Empty the bladder frequently. Take showers instead of tub baths. Keep a diary of urinary symptoms, and empty the bladder completely. Okay, I think this is a good time to take a break. We will close out this video and come back with pyelonephritis in just a moment. Thank you.